Thank you for having me. Just to introduce myself, my name is Allison Giddens, and I'm one of the radiologists here at Cooper. I did my radiology residency here at Cooper, and then I decided to do an extra year for fellowship dedicated to breast imaging and intervention. And since then, the majority of my career has been here at Cooper, working alongside excellent surgeons and my division of other fellowship trained breast imagers. So I thought it would be nice to review some of the questions that I'm asked most frequently from friends, from patients, family members, and hopefully it will clear up some of the most commonly asked questions and also some fears surrounding getting mammograms. So the first question I'm usually asked is, when should I start? And our recommendation from the American College of Radiology and the Society of Breast Imaging is for women at average risk to start screening at age 40. And as long as everything is okay with that screening, to continue to do so annually. Now, there are certain patients who have very strong family history of breast cancer, or who have a known genetic mutation, who should start screening earlier, but hopefully they are, in contact with a breast specialist such as Dr. Flannery or an oncologist, and those are special circumstances. So when you come in for your mammogram at our center, if you're a screening patient, you'll be asked a series of questions. The technologist will explain everything to you. You'll have your study done, and then you'll go home. One of the radiologists will review your study, usually that same day, and release the results to your physician. So what you'll get is a letter in the mail or on the Cooper website that releases your results, and it will also tell you what your breast density is. So a lot of people ask me about their breast density and what does it mean. So I like to use the analogy that if you have a very cloudy sky and you're looking for a very small airplane, that's sort of what a dense breast looks like. So there's a lot of white tissue on the mammogram or the x-ray, and our job as a radiologist is to find that little airplane or that little abnormality through that tissue. If you don't have a dense breast and it's more fatty, then it's easier to find that little airplane in the sky or on the mammogram. So dense breasts definitely make it more difficult to interpret the mammogram, but not impossible. And we're very experienced in reading dense breast mammograms. We offer 3D mammography here, which has made it more sensitive, those mammograms, and we call less people back as a result of the 3D mammograms. People ask me, they're worried about the compression from the mammogram and why do we have to compress their breasts, and is it always necessary? And there's several reasons why we do that. First is we don't want the breast to move during the picture. We don't want a blurry image that will make it very difficult to see anything. It also helps to spread out the tissue so we can sort of see, we don't have overlapping structures, and it makes it easier to see if there's some abnormality. And also when the breast is thinner, it takes less radiation to penetrate the breast, so there's less radiation to the breast tissue itself. There are certain things that you can do to help if you're nervous about pain from the compression. You can sometimes schedule it at a time of the month that your breasts are less sensitive. Typically right before your menstrual cycle or during it, you may be more sensitive, so you might want to schedule it later in the month. Some of our paddles now are made in a more curved position, so it makes it a little bit easier for the breast in compression. And some patients who really have a difficult time might take Tylenol or ibuprofen about half an hour prior to their exam. But for the most part, everyone does very well with the mammography. So if you get a letter in the mail or you get a phone call that says that there's something abnormal with your mammogram, please don't fret, especially if it was your first one. Sometimes we have to get used to the appearance of your breast. I like to say that everyone's breast is like a thumbprint or a fingerprint, so everyone's breast looks different. In a day, I probably see very few breasts that look very similar. So it takes time for us to get used to the appearance of your breast. And if there's something we are concerned about, we'll have you come back. The radiologist will always be there to give you your results. You might get another mammogram picture, you might get an ultrasound, but at the end of that exam, you will have your answer, and the majority of the time, everything is just fine. So please, you know, don't, I would be equally as anxious, but I always want to tell people that, you know, everything is going to be okay.
I have a funny story in regards to that. So, when I first started practicing, I remember my dad actually calling my office, and trying to get a hold of me. He had texted me, and I missed it. I was in the middle of hours, and his text while my staff was trying to get a hold of me. I'm reading my dad's text, and it says, "What does a word malignancy mean? Your mother got a mammogram report." So I was getting to the phone as I was reading the text, and I said, "What do you mean? What does the mammogram report say?" And obviously there is the verbiage at the bottom of the report talking about the density of your breasts, and also in regards to explanation basically. And I think there was a word about malignancy being there, but that's the only thing my parents obviously saw. And so then immediately they called me, the breast surgeon daughter, and said, "What does the word malignancy mean?" And I remember having to talk them off the ledge. I mean, we're obviously lucky to be able to laugh about it now, but I think generally when I also see patients in the office, sometimes people get lost in the, how much verbiage there is. Of course, we take every opportunity, especially on a document, to be able to explain fully what's going on and what we're looking for. But, most of the time that verbiage may not, apply to you directly, but sometimes people are just reading it and I think can get panicked. So I do from time to time have to talk people off the ledge, including my own mother. So, I understand the anxiety from
Of
patients.
course. And I think that's what makes breast imaging so nice. It's a field I love
Hmm.
because we have so much patient interaction. I would never want someone to leave the office without having the result that they came in for. We have the chance to explain things and to help schedule additional appointments if they need to see a breast surgeon, to sort of help relieve the anxiety of the appointment, because it's different being on this side of it as being on the patient side of it, and we've all been there with family members, um, and you sort of put in a different position. So yes, I agree.
One of the things Dr. Gittens also mentioned earlier in regards to some of the common questions, you mentioned about high risk patients. And obviously, patients' risk factors, both personal and family, history, definitely can contribute to higher risk of developing breast cancer in your lifetime. But sometimes, what I have to say, what I've noticed is, for whatever reason, patients, when, outside the medical, system or whatnot, and underwent a genetic testing for whether they met the criteria or not. And, they got the BRCA testing and they'll tell me, I'm BRCA negative, so I know I'm not going to get breast cancer. And a lot of the times I do have to take the initiative to explain to the patient, to figure out what else is going on in the family history. For instance, I met a patient yesterday. She told me, I'm out of the woods. I got BRCA tested and I was negative. And I said, "Well, why did you get tested?" And she told me, "Oh, my mother had breast cancer at an early age." And so I dug further. I said, "Well, did your mom get tested for BRCA gene?" And she said, "Yes, she did." And I said, "Well, was she positive?" And she told me, "No, she was negative." And at that point, I had to explain to her, when we go through genetic testing, of course, if we have a positive test, then we can fully explain to the patient, this is what caused your breast cancer. But a lot of the times, if we really tested everybody with breast cancer, we say only maybe about 5% of our patients with breast cancer really have a genetic mutation. The rest of the people, even with family history, we really can't explain. And so if your mom had breast cancer and she was actually negative, and you get tested and you're actually negative, I can't look at you in the eye and say, I can't explain why your mother had breast cancer. And so this is a concept that sometimes I think I have to explain to the patients, that genetic testing is not so black and white as we would like it to be. Now, if somebody had breast cancer and they were actually positive, and then their children got tested and they're negative for BRCA, mutation, then I say, you know what, you're out of the woods. Your lifetime of developing breast cancer is really of the average risk, of people who don't have a family history of breast cancer. But again, that's why I think it's so important to understand your full history in regards to that.
So when someone's at higher risk, we have
Hmm.
certain screening protocols that we use for them as opposed to patients who are at average risk. When our protocol is to do mammograms and then every 6 months do an MRI and then a mammogram
Hmm.
and an MRI. This way we can see patients every 6 months, and MRI is really our most sensitive test for detecting small early breast cancers. Um, do you have a lot of patients who are on board with, more aggressive screening techniques?
No, I think, people usually really like the idea of possibly not going more than 6 months with some type of imaging study if they're at high risk. Now, potentially they could do the mammogram and the MRI at the same time, right? You'd all get it out of the way in January and then come back in a year. But I think even from my perspective, if somebody is high risk, certainly we want to examine that patient with a clinical breast exam every 6 months, not just once a year. And, I personally really like it if somebody comes to me with high risk. They got the mammogram, say in January. I examined them after their mammogram. Everything clinically still feels fine. And then I'll give them usually a prescription for their MRI in July, 6 months before they come back and see me. I know there's also some conflicting reports about self breast exam and, are we detecting something that ends up being important or not? But in general, I think patients know their body best. I always tell patients, you're not going crazy, doing your self breast exam every day, because we've all seen patients who do the breast exam every day. Just do it once a month. Pick a certain time of the month, either it's the first or the last of the month, and do it in the shower. Get into the habit of knowing how your breast tissue feels. Some people really do have dense breasts, and it's hard to, usually patients will tell me, well, my breasts feel really lumpy. I don't know what I'm feeling. Is this different? Is this new? And so those are the people that I even more encourage to do the self breast exam, because eventually they'll get to know what their breasts usually feel like, and they'll pick up a different lump that they didn't notice before. So, I think just staying vigilant about staying on top of your breast health in general is really important.
Yeah, I sometimes mirror that same recommendation after, if they come in with a lump and it's just really normal tissue. I say,
Hmm.
tonight go home and refeel this area. Now you know that this is normal for you. And so you have a baseline of what's normal. So I think
Hmm.
it's reassuring to the patients to have that information about their own bodies.
Absolutely. I also get a lot of questions in regards to underwire bras or deodorants, and I always thank my patients for continuing to wear deodorant, as we have known that there have been really no studies that demonstrated any higher risk of developing breast cancer based on wearing an underwire bra or deodorants. I think a theoretical risk, if you have an underwire, is there any any downside, because is the underwire causing any blockage of the lymphatic system? I think that's the basis for thinking that maybe that may lead to a higher risk of developing breast cancer, but that really has never been demonstrated in research. And again, I can kind of understand where the thought process came from in regards to deodorant, in regards to just putting chemicals on your body. But so far, we really haven't been able to demonstrate that. But I do really talk about it. I think in general, what we have found to be associated with, a higher risk is, if you are on the obese side, certainly the heavier you are, we certainly know that that may contribute towards a higher risk of developing breast cancer. Increased alcohol intake. Now, we all have been through the last 6 months of COVID-19, and I'm sure everybody's alcohol intake, including yours and mine, have certainly gone up. And we won't talk about that, but in general, we say chronic use of, alcohol intake has been linked with breast cancer, risk. Now, on the other side, though, I actually had a patient who was diagnosed at a very young age, and I met her at the time of her diagnosis, and she came to me crying. She came with her mom, and she said to me, I wish I could have a glass of wine, but my primary care doctor told me, don't you dare touch any alcohol. And, I held her hands and I said, we already have breast cancer. Go home and have a glass of wine. I think it's all about how to do it in moderation, right? I mean, we're not drinking with blackout drinking every day, because certainly that over time is going to contribute to that. Really, a glass of wine here and there, is not going to change that. And certainly it's not going to make your breast cancer worse. So we're not abstaining completely from a glass of wine here and there when we're going through an actual, treatment of breast cancer either. What other questions that I have gotten? Oh, one of the recent questions that I have gotten from patients was, do I have to have a mastectomy when with my breast cancer diagnosis? And I think historically that's a very eye-opening statement. I think, unfortunately, historically, breast cancer surgery was a very morbid procedure. So, not only did we have to recommend a mastectomy, we had to recommend what's called the full axillary nodal dissection, where we're removing all of the lymph nodes under your armpit. And, long time ago, we also really remove all of the chest wall skin, the muscle. I mean, it was just a horrific, horrific procedure. Thankfully, over the last, few decades, we have really committed a lot of research and clinical trials to find out that we do not have to really do such a morbid procedure. Actually, the results are the same. And now we do know that for certain patients, not all, but most patients, can qualify for a what we call breast conservation therapy or breast conservation surgery. Another term for that is a lumpectomy. Now, everybody has a different, breast size. I don't also tell patients, everybody qualifies for lumpectomy now. Sometimes patients will come in with a very large, cancer, unfortunately, compared to the rest of the breast tissue. And so it's really a personalized decision for patients. But I think in general, we have really made a lot of progress in the past few decades where we don't have to jump to, having to remove all of your breast tissue and whatnot. And we also really can offer breast reconstruction in the event that we have to do a mastectomy. We typically really pair up with a breast reconstruction plastic surgeon who will actually be in the room with us at the same time. So I'm doing the first surgery where I'm removing the cancer, and then the plastic surgeon is actually right there with me, doing part of the procedure to then take over once I'm done with my part of the cancer surgery to then start rebuilding the breast. And so the patients aren't necessarily, waking up with a flat chest unless that's what they desired. I do know that there's also some movement towards going flat, and it's ultimately really, I tell my patients, it's totally your personal choice. but also, patients have to know that if you desire to go with a breast reconstruction, it has to be covered by insurance. It's now considered to be a part of our breast cancer treatment. It's not considered a cosmetic surgery.
What about for
Um,
the other breast, the contralateral breast?
so that's as you know, a semi-controversial topic. Luckily, it is still considered a personal decision. Now, if you have somebody who has a genetic mutation like the BRCA mutation, then the recommendation is for what we call a bilateral mastectomy or a double mastectomy, where you may not have a cancer on the other side, or you may not even have any cancers in either breast, but we're doing it from a risk reducing standpoint, and that's absolutely considered standard of care. And obviously, the breast reconstruction is covered as part of that procedure. For patients who have a one-sided breast cancer where they desire to go with what we call contralateral mastectomy at the same time, it's really a personal discussion I do have with my patients. We do know that what we call overall survival, how long does the patient live, whether they do the other side or not, really doesn't change unless you have a genetic mutation. But again, it's really a personal decision. I tell my patients, I'm the one that's supposed to tell you all the data that's out there, all the survival benefits and whatnot. But ultimately, after I present all the data to each patient, she or he has to really tell me what they're able to go to sleep at night the next night. And luckily, so far, the insurance companies have covered the procedure, barring that this is not totally outside the realm of what's considered standard care. That might change. We don't know. But so far, I mean, I think that the personalized decision for patients, it really is important, has always been, and I hope that really continues. Um, One of the patients or questions that I get a lot about breast imaging also is if they have breast implants. So they got implants not because they have breast cancer, before. It's really for augmentation purposes. They had a cosmetic surgery, and they wanted to go big and they have implants. What kind of imaging do we have to do? And do they, are they at a higher risk of developing breast cancer?
So we're very comfortable imaging breast implants. You will have probably two additional pictures taken than a person without breast implants. We try and I know it sounds a little rough, but it's not. We try and move the implant out of the way of the
Hmm.
picture so we can pull the native tissue forward, so we have a good idea or a good image of what your breast tissue looks like. A lot of the implants are behind the muscle, which makes it easier. I think that's most likely how they're done today, behind the muscle.
Hmm.
So it's not hard for us to get it out of the way of the film. But we're very comfortable with doing them, and we get beautiful imaging from our technologists who are comfortable with it as well.
I think recently also, both of us, I think, have been asked in regards to the media surrounding the risk of very special type of a lymphoma that
Mm.
has been linked with a certain type of a set of breast implants. And so when the focus was on that in the media, I remember just getting actually a lot of phone calls from panicked patients saying, "Oh my gosh, like what's going on? Is this all kinds of breast implants?" And what I've explained to the patients is really it's very rare. It is a treatable form of lymphoma, and it is not linked with every kind of breast implants. What we've found out so far is that it seems to be linked more with texture type of breast implants. And so I've had to kind of, walk patients through and see, what type of breast implants do you have? Typically, patients will still have that card in their wallet as to, what they've been implanted with. And so I've walked them through in regards to that. And if there's any questions, we always track down from the plastic surgeon's office. I think the plastic surgeon's offices have also been very vigilant. They actually have sent out letters, tracked down patients, and said, hey, you went through a breast reconstruction or breast augmentation a while back, and you do have the textured implants that we think have been linked with this procedure, and they're tracking down patients as well. And so I think, that's been really, helpful, kind of alleviating the extra risk, or anxiety from patients' perspective.
And those textured implants are off the market.
Correct.
Yes. So no one has to worry about having textured implants placed anymore.
Right. Exactly. Right. Right.
Well, that's good. I don't know if they're not recommending all of those implants be changed.
No, so that's a good question for also the plastic surgeons. I do think that some patients are asking them, and it's again like a very personal decision. The recommendation from the society is not that we do routine removal of the implants, but they obviously undergo a closer monitoring, maybe,
Right.
from a clinical standpoint, and maybe, more breast imaging from that standpoint. But my understanding is that we're not recommending routine removal of those either. And the risk seems to really vary, from study to study. So I think we just have to know more and obviously, figure out exactly what's going on in regards to that.
And from a radiology standpoint, I think those patients, if they did have an issue, they would present with some fluid collection around the
Hmm.
implant. So it's easy enough to evaluate with an ultrasound to see if there's some change around the implant.
Exactly, exactly. Another question that I get asked very often is, because I talk to a lot of patients or I'll give lectures and they'll say, well, you say then the breast surgery has made a lot of progress. Is there anything else other than not doing a mastectomy that you do now that really has changed? I will say, there's a breast fellowship, breast surgical oncology fellowship that we breast surgeons do. And obviously, I always explain to the patients the primary focus is obviously the oncologic outcome. Are we doing the right cancer surgery for the patients? But I'm also very cognizant. I'm a woman. Not that I play any downside to our male, partners, obviously, but we really do pay attention more as to how are they going to heal. I really try my best to hide the incision in any way. I'll typically try to hide the incision around the nipple areolar complex border, or laterally or under the breast as much as I can. And I'll explain to the patients when they're in my office. Sometimes I'll draw out or I'll point out where I think I should make the incision, compared to where the lesion is. But ultimately, I'm also very realistic. I won't try to struggle to hide the incision, to then not end up getting what I need to get. And I'm very open about that. Another thing that we are able to do is nipple sparing mastectomies. Not everybody meets the criteria for nipple sparing mastectomies, but they can. It really depends on, again, the location, or how advanced, or where, how big is your cancer, where is it in location to your nipple, what size is your native breast size in general. And so there's a lot to it than just saying, is it a small cancer, and that's it. But for patients who meet the criteria for being able to do the nipple sparing mastectomy, we really have found that it leads to better sexual health, and psychological health in general. And so that is definitely one of the things I explain to the patients. The downside of doing a mastectomy, I'm also very open about it. I think a lot of the patients may not understand when you do go through a mastectomy, no matter what I try to do, no matter how great a breast surgeon I am, most of the time the patients actually end up very numb across the chest wall, including with nipple sparing mastectomies. So cosmetically, nipple sparing mastectomies look beautiful. Sometimes patients really come to me saying, I look better than I did, before the breast cancer diagnosis, but they're completely numb across the chest wall, including the nipple. And so if, patients nipple foreplay and sexual health. And in regards to that, that's very important. I'm very open with them. It looks nice, but that sensation is really gone, and that may really change that aspect. But even with that, we have found that the sexual health, overall health, in general, is improved with nipple sparing mastectomy, as long as the oncologic outcome isn't compromised. So I'm
Is
very
that
open about that.
a common technique, like the nipple sparing, for patients who are appropriate candidates when they're getting a prophylactic mastectomy?
Absolutely. But again, the size of the breast really matters. We have now, my plastic colleagues have really now gone through situations where sometimes it's prophylactic, there's no cancer, but for instance, they'll present with very large, what we call ptotic breast, where they have droopy breasts. And those large side droopy breasts, if you save the nipple and try to do something with the reconstruction, the nipples will really go sideways or all over the place. And I'll explain that to the patients. But now, plastic surgery has also made really a lot of improvements. They'll do something really smart where they'll actually reduce do like a breast reduction for patients, and then actually wait it out, a good 3 to 6 months, and make sure that, the breast tissue, the secondary tissue now has obviously healed, but also the new blood flow to the nipple has really settled in, so that when we make a new incision and try to save that nipple, the blood flow to that is not compromised. There's more to it than just trying to go under the skin and the nipple. We have to make sure that when we do these procedures, that the blood flow is maintained, that we're not losing the nipples. There are some things where sometimes patients will come in and they're active smokers. In those patients, what we call nipple necrosis, or the risk of loss of nipple, is really significant. And so I tell them this is really pushing the boundaries. So again, I'm very open with a lot more options. I think also, older breast surgeons, or, obviously decades ago, we never thought about saving this. We never thought about hiding the scar. Like, what are you talking about? All you have to do is get out the cancer, right? And so this is definitely, a different era. And I think it's just great. But there's a caveat. Not everybody, obviously meets the criteria for it either. And so that's why it's so important for you to be seen and be examined from a personalized approach.
But it sounds like you're thinking more in terms of life after breast surgery,
Absolutely.
like psychosocial wellness and sexual health, everything, once the cancer is done and you have to live your life again.
Absolutely. And so many patients come to us, right? I mean, you've seen them all. They're desperate. They're so upset.
Mhm.
How is this going to work? Am I going to live? Am I going to lose my hair? I mean, we go through so many emotions with the patients. But there's the other side of it. I'm just so thankful. I mean, you and I are both so thankful to be able to follow these patients and be on the other side and say, hey, now I have patients where I'll tell them, do you remember how crazy things were? We went through all of it. Look, and we lived through it. And, I see their, sisters, I see their daughters. There's definitely the other side of it, but we have to wait. There is the other side. But as we're going through it, it can be very difficult and very challenging. And I think that's why it's so important for patients to be seen at a center like MD Anderson Cooper, where the multidisciplinary team, it's not just me, it's Dr. Gittens, it's a radiation oncologist, it's Dr. Grana, the medical oncologist. There's a whole team that's really following this patient, really more than just a patient. It's a person, and it's a family that we're watching. And I really can't stress enough about the utility of being treated at a large center, such as ours.
Yeah, I get very excited to see the patients,
Yeah,
after when things are done and they're coming in for just their annual checkup. It's very exciting. I think
yeah.
they think I might
I
be crazy when I want to hug them. I mean, not in COVID, but in
No, I
regular
love,
times.
right. I tell them, oh, this is, I'll look at the list and I'm like, oh, I have some social visits today, and
Yeah.
it's just so great. We ask about each other's family, how are you doing? Of course, I'm still checking their breasts and making sure everything is fine. We're reviewing their mammograms, but to me, it's not just about the cancer part of it, it's the rest of it, and I mean, personally, that's really the reason why I personally chose breast surgery. Breast surgeons really train mostly as general surgeons first, and then we decide to really focus on breast surgery, right? And to me, it wasn't just about doing surgery. It wasn't, hey, I'm going to cut this out and be done with you. It's really what comes after and what even during the discussion, I'm very nosy about patients. I'll ask them if the husband is there, they're emotional. I learn about, how many kids do you guys have? How old are they? How are they coping with the hybrid, schooling? We're very nosy about the family dynamics, but I mean, really, that's what's important about all of this. And I really enjoy that aspect and not just the surgical part of it. And I think that's what the patients appreciate also.
We have a couple questions that have come in. First for Dr. Gittens, what is tomosynthesis?
Tomosynthesis is another word or another name for it is 3D imaging. So in, before 2011, I believe, when it was approved, we just had 2D pictures. So basically an image was taken and we looked at it from a 2D perspective. Now with 3D imaging, we take small slices of the breast tissue, small image or slices through the breast tissue, and then I can review all of those slices to see what's normal tissue and if there's anything hiding in that dense breast tissue. So it's been really amazing. What we found is that we find more cancers this way, especially in women who have heterogeneously dense breasts. But it also reduces the number of patients we have to call back because we're able to see that something we might have thought was abnormal before is just normal tissue overlapping each other. And it's been a really great tool to reduce the number of patients we have to send those letters to ask them to come back for, additional imaging.
Okay. Another question came through that a woman was scheduled to have her mammogram in the spring, but it was canceled because we weren't doing breast cancer screenings, we weren't doing mammograms. When should she come back for her mammogram?
Now. Tomorrow. If she wants to come in tomorrow, she can. We are open for screenings. We've extended hours into the evenings at certain sites and also on the weekends to try and make it more convenient for patients. I understand. I mean, I think the world shut down probably for 3 months at least, and we did our best to keep everyone safe, and we're doing our best to keep everyone safe, but now like in this new world. So we're adhering to all the guidelines. Everyone is, has the appropriate PPE. We're screening patients. We're not having patients wait in waiting rooms with other patients. If they feel comfortable or they don't feel comfortable, they can wait in their car and we can call them as soon as it's time for them to come in. We'll do anything to make the patient comfortable, but I don't want anyone to put off this important screening test.
Okay. Here's another question. I have dense breast. I had an ultrasound that showed lots of little benign cysts. Should I be worried?
No. As long as the radiologist who read those images felt that everything was, benign, meaning nothing looks suspicious, then it's a very common thing to see on ultrasound. And you can follow that in a year at the time of your next mammogram with another screening ultrasound if you have that discussion with your doctor.
Okay.
I have a question.
Yeah.
I have a question for Dr. Gittens. So we talked about spacing out, like for high risk patients with mammo and an MRI. For dense breasts for patients, do you prefer to have the mammogram done and the ultrasound at the same time, or do we do it, kind of every 6 months?
I'm okay. I've seen patients who prefer that every 6 months, especially if maybe they have a high, like they maybe don't meet the criteria for MR, like they're not
Right.
as high of risk, but they still
Right.
feel anxious about some family history or some personal history of something else. And I'm fine as long as their mammogram was normal at that time to see them in 6 months. Most of our patients, and I believe it's for convenience sake, do their study together. But it's really a individual decision. I'm fine either way.
Okay,
Yeah.
this one could
I
go
kind of
sorry.
I kind of leave it to the patients, honestly, because they'll come to me and say, when are you going to order? And I kind of gauge that interest from the patients. And if I
Yeah.
think they can fly for a whole year and obviously everything is fine, then I'll order them both for, the reasons you specified. But some patients I'll say, you know what, we'll do it every 6 months.
Right. Yeah, I don't think that's a bad screening schedule.
Yeah.
All right, here's another question. This is a good one. How does aging change breast tissue? And does it and my breast cancer risk?
So I'll tackle the tissue. It's not uncommon to maintain your breast density. I have 90-year-old women who have this, dense breasts. There is a percentage of patients who their breast density decreases over time. I want to say it's about 30% of patients will have a decrease in breast density, but the majority of patients I see, it stays pretty stable. Things can affect your breast density, weight gain, weight loss, if you're on hormone medication, if you're on like a medication to reduce your risk for breast cancer. So certain things definitely alter your breast density, other than aging.
I think that's a really good question in regards to age and the risk of breast cancer. So typically we say that breast cancer is something that you get when you're older. Now, I'm not going to define the age in which we call older, that's, we'll leave it at that. And so I explain to the patients, typically patients will get diagnosed in their 60s or 70s, right? But on the other side of that, though, is sometimes you see patients who are in their 20s or 30s where they felt a lump and they'll either dismiss it themselves or they'll see a physician that'll say, you're only 20 years old, this isn't cancer. And what I always tell patients is, of course, most of the time, especially when you're young, you'll have fibroadenomas, all the lumps, you have very dense breast tissue. Things will most likely be benign. But I always explain to the patients, if you feel a lump, we ought to be able to explain what that lump is. So we get an ultrasound and it's just dense breast tissue and there's nothing wrong there. I will say myself personally, I will never just examine a patient myself and not get a breast imaging study. I will always back it up. I'll tell her, this really feels symmetrical compared to the other side, but, let me make sure, and I'll always follow it up with something. And if I feel a lump, I'll say, this feels like a fibroadenoma, but again, I'll prove it to myself and to my patient by doing some kind of an imaging like a mammogram and ultrasound to say, see, this looks like a fibroadenoma, this is typical of your age. I don't think that I explain to the patients to say, oh, you're so young, don't worry about it, because unfortunately we do have patients that come in, when I feel like they shouldn't be diagnosed with breast cancer.
Okay, and there's another one. Does race and ethnicity affect your risk for breast cancer?
So that is a very, very hot topic. We just actually held the breast disparity course here at MD Anderson Cooper in partnership with Cornell Medical School in New York. There are different components of it. And as you know, with race and ethnicity, it's a multifactorial, finding that we have found. Now, we have known that African American ladies certainly are more likely to be diagnosed with what's called the triple negative breast cancer, which can certainly be a more aggressive form of breast cancer. They also can be found to be diagnosed at a more advanced stage than, compared to other races and ethnicities. So, that's why we really, why do these gaps exist? And it's a huge deal. And we really have to research more and figure it out. Is it that we're not doing screening studies early enough? Is it that the patients do not feel comfortable unless they're seeing somebody that looks like them? There's so many components to that. But, the bottom line is, there's a lot of research that's ongoing and in my opinion, really needs to continue.
And it needs to include women, African American women in the research.
Absolutely.
Because I think that's a segment of the population that's been ignored in all the other research that we've done. So the incidence of breast cancer is higher in Caucasian women, but the mortality rate is higher in African American women. So that gap is something that we need to close. And like Dr. Flannery said, it's definitely multifactorial.
Absolutely. Now, I think the one thing about triple negative breast cancer is, we always talk and say that it's a more aggressive form of breast cancer. But the upside to having a triple negative breast cancer, I explain to the patients, is actually if we do chemotherapy for triple negative breast cancers, especially upfront, we call that neoadjuvant chemotherapy. The response rate for actually triple negative breast cancer is a lot greater than what we consider less aggressive, like the hormone positive breast cancers. And, we really think triple negative breast cancers behave very differently. And that's why there's so much ongoing research in regards to that. But I always, sometimes you hear the word and patients think, oh my God, this is a terrible form. Everybody's heard of triple negative breast cancer, and you just give up. Like, I know this is going to be a terrible, form of breast cancer, but there definitely is an upside to it. Chemotherapy can really shrink triple negative breast cancers. And so that's why it's important. Another thing is patients have to understand, everything. I always tell patients, don't Google as much because
don't Google anything. Stay off the Google.
Exactly, because truthfully, you and I know patients or people in general will post something. Number one, if they had a really great experience, or more likely, if they had a terrible experience about
there's
something.
There's nothing middle road about posting on that. Right.
Exactly. So, but when you're desperate for information and you're looking online, all you know is you have triple negative breast cancer. You go online, you see terrible post-surgical pictures. There's no, in my mind, there's no upside to that, especially because you don't know if you're in the same boat as that person who posted that. So that's why you and I are here for the patients. That's why I said, look, you call me, you ask me questions as to, I'll tell you what applies to you and what doesn't. And I think that's why it's so important to have a good connection with your radiologist and your surgeon.
Yeah, nothing good comes from doing those Google searches. I don't it will just, like, you'll go down a rabbit hole and you will not be able to pick yourself up, I don't think. So, and that comes from personal advice, personal experience.
I can see that someone's typing in a question, so we'll get to her as soon as she's finished her question. But I do have another one. I have a family history of breast cancer. Should I see a genetics counselor?
So I think, we kind of touched about that earlier. Depends on what type of breast cancer, and it depends on really the history. If you had one person in your family, say, who had breast cancer in their 70s, the likelihood that there's going to be a genetic mutation is low. If you have family history, for instance, though, of what we call premenopausal breast cancer, typically before the age of 50, or even ovarian cancer, family history, that's a red flag. And we usually will say, you know what, you need to be at least counseled by one of our genetics counselors who will then determine whether genetic testing should be done or not. But they'll give you homework. Again, I said it earlier, genetic testing is only as good as the information we know about the patient with the cancer history in the family. So if you had, I don't know, a sister who had breast cancer and she was BRCA positive, and you know that, and if you have, you got tested and you're negative, then you're out of the woods. And so they'll give you homework. The genetics counselors are very good about, taking out the necessary information to ultimately figure it out for you. If there's any question in general, I tell patients, see the genetics counselors, call us, you're considered high risk, and then we'll figure out the utility and obviously getting vetted through to make sure that you get the right care.
Okay. All right. The one participant finished their question. I'm 46 years old this month, and I have never heard of triple negative breast cancer. What is it?
So there are three things that we look at for breast cancers. And basically, I explain to the patients, what does your cancer like to eat? And if we know what it likes to eat, it's like a food supply chain. We turn it off, after the surgery. And the three things that we look at are estrogen receptor and progesterone receptor. Now, these are the female circulating hormones that we all have, even if you're not having menstrual cycles, because your body has a tricky way of producing, obviously, these hormones even after, you're not ovulating and whatnot. And then there is a particular protein called HER2/neu that we know that some breast cancers really like to show. We call it overexpression of it. Triple negative cancer is a particular type of breast cancer where all three markers are negative. And so we test the type of breast cancer. We know that it's not estrogen positive, it's not progesterone positive, and it's not HER2 positive. And so we can't put you on a pill that blocks your estrogen production because we know that it won't work for this type of breast cancer. We can't put you on a medication called Herceptin or Perjeta, that targets the HER2 positive breast cancers because we know that that doesn't work for these type of breast cancers. And so the typical term for this, that we don't know what it likes to eat, we call it a triple negative breast cancer.
What are the other kind of cancers that are specifically not just general breast cancer? Are there other types of breast cancers that are named?
So the most common type of breast cancer that we say are what's called invasive ductal cancer. And I usually, when patients come to my office, I have a diagram of a side view of someone's breast, and I explain to the patients, the breast cancer names will really explain to you where the cancer cells originated from. So invasive ductal, I always, I know we all went to medical school, but I typically really try to break it down. What does each word mean? And so invasive ductal cancer just means that the cancer cells really came from the ducts. And the ducts are, if you look at a picture of the breast, they're basically the delivery channels. If the breast tissue is making milk and you're breastfeeding, the ducts are basically the tunnels, the delivery tunnels that the milk or the secretions come through out through the nipple. And what we found is that invasive ductal breast cancer, basically, when we look at them on the pathology slides, the breast cancer cells have started inside one of the ducts, and then they actually started to go through the wall of the duct, and that's why we call it invasive ductal. If it hasn't gone through the wall of the duct, then I'll explain to the patient, it's called ductal carcinoma in situ, or sometimes we call it stage 0 breast cancer or intraductal carcinoma. I don't know. I think maybe the pathologist came up with all the different names explaining the same thing to maybe confuse the surgeons. I don't know. I love my pathology friends. But basically, it's all explaining the same thing where it stayed inside of the ducts. There's also a different type of breast cancer called invasive lobular cancer that didn't start from the duct tissue. It actually started from the lobular tissue. And so it really depends on, basically, I just break it down with the patients as to the words of the specific type of breast cancer will typically tell you where it came from and where we are.
Okay. And how about inflammatory breast cancer?
Inflammatory breast cancer is a different type of breast cancer where it is aggressive. Okay, it develops very, very quickly. Where you would see, you may not even necessarily feel a specific lump, but you'll see overlying the breast or the skin of the breast that there's all of a sudden a lot of engorgement of your breast tissue. There's redness, there's swelling, and it really looks almost like you have an infection of the breast. Sometimes they come in with a lump, but they don't necessarily have to come with a lump. And I think how the inflammatory breast cancer works is that basically there's tumor cells that are going through what we call infiltration of the lymphatic channels, the channels that we have in the breast tissue that are draining the lymphatics into, outside of the breast. They're basically being overwhelmed by abnormal tumor cells, and it happens very, very quickly. Now, not everybody has inflammatory cancer either, and particularly patients who are breastfeeding, or maybe you have a nipple piercing where you have an infection of the breast. Just because you have redness or swelling of the breast obviously does not mean that you have inflammatory breast cancer, but it certainly you need to be checked to make sure. So if I have patients who come to me, they're breastfeeding or they have a nipple piercing and they have a really ugly looking breast and they have a collection, what we call an abscess, I have a reason for that. You have a piercing or whatnot, but I don't just put them on antibiotics or drain them and forget it. I always follow it up with some kind of, again, a breast imaging study, and I follow through to make sure that there's resolution of the symptoms. And the clinical picture is really different with the inflammatory cancer in that they'll tell you it really happened over a quick onset of time, and then we'll figure out the rest of it, including the imaging studies.
The imaging is very characteristic for inflammatory cancer. So if the patient has it, then it's not hard to see on a mammogram. There's a lot of skin thickening. There's a lot of thickening in the breast, a lot of swelling in the breast. So very characteristic of inflammatory cancer.
Okay.
Absolutely.
All right. We have one more question. I think this will be our last one because it's getting close to 7:00. The question is, if you have dense breast tissue, are you automatically supposed to get additional imaging? I received a notice 2 years ago stating a dense tissue issue, but was never advised to get an MRI or ultrasound.
So, sorry, here and there are notification laws in about 28 states right now. New Jersey is one of them. So we are mandated by the state to let everyone know what their breast density is. That is why everyone gets a letter in the mail, and it will tell you if you have either heterogeneously dense breasts or dense breasts. The recommendation is not to automatically get any additional study. The recommendation is to talk to your OBGYN, your primary care doctor, whoever sent you for your mammogram, and talk about what additional tests might be right for you. And there are always risks and benefits to any test. So ultrasound is a nice way to look at the breast tissue. In addition to mammography, there's no radiation. It's a comfortable exam. You're on your back. You're not being squeezed like a mammogram. It's quick, and it's a nice way to see if everything looks normal. The caveat is sometimes we find things that are not cancer, but there's when you look, you find. That's what I tell most patients. So it may end up that you end up with a benign biopsy, or you end up having to come back in 6 months. So we have to weigh the risks and benefits for every patient, what's right for them.